So now I have the great honor of introducing Dr. Kenneth Resnicow. Dr. Resnicow is the Erwin Rosenstock Professor of Health Behavior and Health Education at the University of Michigan School of Public Health. He also holds a Professor of Pediatrics in the School of Medicine. He's the Associate Director for Community Engagement and Health Disparities Research at the University of Michigan Rogel Cancer Center, and the Chief Scientific Lead at the University of Michigan's Center for Health Communications Research. He is an internationally recognized expert in the design and evaluation of health promotion interventions and motivational interviewing. His work over the past 30 years has focused on designing and evaluating behavior change programs for a wide array of health behaviors that include smoking cessation, breast cancer treatment, genetic testing, COVID-19 vaccination, cancer screening, car safety, substance use, youth violence, and risk behaviors, and gun safety. In recent years, his work has increasingly entailed novel behavioral tailoring methods and the incorporation of e-health technology to enhance the impact of health messages. Please join me in welcoming Dr. Ken Resnicow for his talk.
Hello, I'm Ken Resnicow from the School of Public Health and the Rogel Cancer Center at the University of Michigan. Today, I'm going to talk to you about some advances in digital e-health and m-health interventions and show how some of these innovations can be applied to injury prevention. Specifically, I'm going to show you how geofencing has been used in other health domains, as well as an example from Pat Carter's studies of how it can be used for injury or violence prevention. Then we'll talk about how natural language processing is improving the artificial intelligence of our apps and how it can be applied to behavior change interventions. Then I'll share with you some examples of behavioral inference, that is, measurement and classification of behavioral status without survey input from the participants. Then we'll briefly discuss how virtual reality has been used in other health domains and how it might be applied to injury prevention. And if there's time, we'll also touch on some recent disparity data that is relevant to substance use and injury. Let's begin by geofencing. Many of you are aware that your phone has various location services embedded in it. We use some of those location services across several interventions, and I'll begin with our first foray into this field. Here, we work with a faculty member from the School of Pharmacy at the U of M named Mike Dorsch, and in this case, we were trying to lower the sodium intake of individuals with hypertension. The app, downloaded on their phone, asked the individual to mark where their primary grocery store was, where they eat at home and at work, and then every time they got within X number of meters of those venues, the app would wake up and say, "What are you shopping for?" And in this case, the individual was shopping for mustard. Well, the app then offered options for low sodium foods that they could select. The individual also could scan the barcode of that food and get in return the sodium content of that food. The same can be done in this case, we had geocoded where the fast food restaurants are. When they entered at Chipotle, we asked them what they were thinking of ordering. And then, just like we showed you with the mustard purchase, it gives some options for the user of lower or better choices that are lower in sodium. In this case, this food has lower sodium than this food. This is all happening just in time, in vivo, as the person is in the restaurant. And finally, we give the individual positive feedback about the choices they've made. Here, we expanded the geocoding to have dyadic interaction. So in this case, this is an obesity prevention intervention, and there's an app for both the parent and the team. In this case, the geocoding or geofencing involves fast food restaurants in the state of Michigan. So the mom's version of the app, when she got near a fast food restaurant, in this case, McDonald's, would ask a few questions. For example, is your daughter with you? In this case, her daughter Keisha was with her. Well, given that, we're going to ask her to serve as a role model. How about you both try to eat something healthier today? How about you help Keisha meet her goal? It also asks Keisha, who was with her with her own version of the app, about what she's planning on eating. And it gives her some feedback for healthier foods. It also reminds her of goals she set earlier for when she would be next in a fast food restaurant. Then it asks her at the end of the encounter whether or not she met that goal. Then it allows, in this case, the teen to set a goal for the week, and that goal is communicated to the parents app, who is now aware of what her daughter is trying to achieve, and again, can be supported of her next time they go into a fast food establishment. So you may ask, how might geocoding and geofencing be applied to injury prevention? Well, Pat Carter, one of the co-directors of the Injury Center, has actually created a functioning app that can be used to lower injury behaviors, particularly gun carriage. Project Interact has many intervention components. I want to focus today just on the geocoded risk location component. So the individual teen marks on the phone where they've had an incident, maybe where they fought with someone, maybe where they may have purchased or used substances. And whenever that individual gets near that venue, the app wakes up and pushes a message into their phone. And that message is something that is culturally tailored and uses CBT strategies. How you geocode is quite nuanced. You can choose between various platforms to locate the individual, ranging from the least precise cell tower to the most precise beacons. Beacons have to actually be installed in the microenvironment, such as in retail operations and supermarkets. You have to decide how long do they have to be there before the app triggers the message, and how close to the actual venue do you want to trigger the message. Now let's talk about natural language processing. NLP has tremendous potential for improving the effectiveness of interventions, particularly this idea of just in time, that we can intervene with someone right when they need it. So I'm going to share with you a couple NLP innovations that our team has been working on. First, we trained our agent how to distinguish between low and empathy counselors. How did we do that? We took 276 counseling sessions that used motivational interviewing, and they were coded whether or not that session had low or high empathy expressed by the counselor. And then we taught the agent to distinguish features that discriminate between low and high empathy counselors. And for example, words per turn every time they speak. In high empathy encounters, there is actually fewer words by the practitioner. In low empathy encounters, there is more words from the practitioner. Similarly, in high empathy encounters in blue, the counselor is better able to match the linguistic words and style of the speaker. Now, using this information, plus some acoustic features of the conversation, the agent is able, with about 80% accuracy, able to classify encounters into high or low empathy. Next, we wanted to train the agent to recognize reflective statements and questions. So using those same 276 encounters, we coded each utterance, each exchange between the therapist and the patient. And we hand-coded them into questions or simple reflections and complex reflections. And here's an example just of how a few utterances were coded. And using various advanced NLP algorithms, we were able to, with significant precision, classify utterances as either reflections or questions, with about, as we said, 80% accuracy. Now, you may ask, what's the use of this? Now, one potential application of this agent is to give feedback to professionals learning motivational interviewing or other counseling. So here we could give feedback about how many reflections they used in the last session, in the last week, in the last month. Same with their empathy score. We could give them feedback for how empathetic they've been today, last week, last month. And then we can give them tips or training opportunities to boost their skills. For example, if this person was not expressing as much reflective listening as we would like, we could direct them to some resources. The golden ring of motivational interviewing AI and NLP is actually, of course, generating counselor content. What the agent does is it takes client statements and it looks up reflections that have been used in the past and tries to match the library of reflections to what the client just said. And it does that by using synonym and other analysis to try and figure out what is this person talking about and what's the best reflection I can pull. So here's what it actually looks like. The agent started by hearing the patient saying, I had a really hard time sticking to my diet. Well, it figured out it was talking about weight loss or diet. It found the next best reflection that's been used in that domain. And then it generated its best guess, combining the content and the retrieved reflection to generate a new reflection that is responsive to the client statement. Next, they wanted to know how was the quality of these generated reflections. So they had humans rate the human-generated reflection, or what we'll call the ground truth, compared to the AI or machine learning version of the reflection, and rate them on 3 dimensions: relevance, the depth of the reflection, and the quality of the statement. And what we can see in the upcoming slide is that when you compare the pink to the blue, the ratings of humans on those 3 dimensions, relevance, reflection quality, and overall quality of the encounter, is that when you use that retrieval technology, which is looking at the library of reflections combined with the content analysis, the overall rating of the AI or machine learning generated reflection is very similar to the human generated ground truth. This is great promise for the potential to eventually create true AI trained intervention apps. Now I'd like to talk about behavioral inference. This is where we code, classify, detect someone's behavior without necessarily asking them for survey data. We do it through their phone or through other natural occurring paradata. Now you're already familiar with this with your phone. It measures your physical activity, and if you want to see it, you can get that feedback. You also have sensors in your car that if you're swerving or moving across lanes without signaling, it might give you an alert that you might be impaired or tired. I want to give you 4 novel ways that behavioral inference has been used recently, and then we'll ask the question, can we use this for injury prevention? So the researchers here asked whether or not natural occurring paradata from interactions with smartphones, can they be used to predict your drinking behavior? And to answer this question, they worked with 30 young adults ages 21 to 28 who had a history of heavy drinking. And then they analyzed interactions with the phone and then correlated them in effect with the self-reported drinking of those individuals. And what they found is people tend to check their phones much less frequently as they begin to drink more and more. They also found that the interactions during moderate drinking are briefer, but during heavy drinking, the interactions are longer, sort of slurring your interactions. And finally, during heavy drinking, less so moderate drinking, but during heavy drinking, the orange bars, your typing speed slows down, your error rate goes up, and the number of corrections you make goes up. So taking into account all this paradata, they were about 97% accurate, classifying people into those 3 different drinking categories. Again, without having to ask in the moment what they're drinking, just their interactions with their phone gave us this behavioral inference. Another example of this is the puff marker device. Here we're trying to determine whether or not they're smoking a cigarette without having to ask them. So they use 2 sensors, a breathing apparatus around the chest, and accelerometers worn on the wrist. And these are what the accelerometers look like. They knew that during smoking, there's a particular combination of movements. The hand comes to the mouth, and there's a deep inhalation. Walking and eating also have unique combinations of breathing and hand movement. And here's how those 3 behaviors look like. The respiration and the accelerometer wrist data. Smoking, walking, and eating look very differently. So, of the 32 smokers who had relapsed by lifting their hand and breathing and putting their hand to their mouth to smoke, they were able to detect 28 episodes of smoking with the dual sensors, and just with the wrist model alone, 24 of 32 events. Another example of behavioral inference is the work by Saib and Moore, where they looked at phone interactions and location to infer someone's depressive state. So 28 adults carried a mobile phone with specific sensor data acquisition set up on the phone for 2 weeks. And they also frequently completed the PHQ-9, which is a self-reported measure of depression. They looked at a few things. They looked at the movement of the individual based upon GPS, okay, how much time they spent at home in particular, and how much they traveled from their home. And they also looked at how much they used their phone and for how long. What they found is that movement and phone usage were strongly correlated with PHQ-9 scores. Specifically, what they found is those with greater PHQ depressive symptoms visited fewer locations, spent more time at home, and covered less geographic space during the day. They also used their phone more and longer when they had greater depressive symptoms. So where else can behavioral inference be applied? Well, it's already used for fall detection. Both devices like the Apple Watch and the Kenneth watch, they already can detect whether or not you've fall, tripped, or slipped. But could we now extend some of this technology to detect other substance use, like vaping, marijuana, cocaine, or heroin? There might be very specific hand movements when you use cocaine, or head tilts, and certain movements when you're using heroin, both injected or smoked. You might be able to detect those. We might be able to detect predisposition to violent behavior by your heart rate or your respiration rate. We might be able to coach parents on how they talk to their kids about health or substance use. We could have a passive Siri or Alexis device listen in. Of course, we'd need permission to make it transparent, but we can, using a combination of the NLP technology we shared with you and some of this behavioral inference, give parents parenting tips such as, hey, you seem really angry today, or why don't you try to support your kids' autonomy a little bit more. We might be able to detect adherence to medication and hopefully eating behavior. A final example of behavioral inference is the Screenome project that's come out of Stanford, Reeves, Rahm, and Robinson. And what they've done is quite fascinating. They take a picture of your screen every few seconds, and then through machine learning, they've been able to train the software to detect what is it you're seeing. They look at both the visual images of what's on the screen as well as the content. They look at the content of what the person is reading, and they look at the content of what the person is generating. And from this Screenome, they're really able to understand a lot about what that person is doing. So let's take a look at someone's screen use over a month. Now the blown up is a row is 1 day, okay? And the screen is sampled every 5 seconds each day, in this case over a month, but we're gonna just focus on one select day for participant A and participant B. What you can see on this day, participant A spent a fair bit of time on social media, which are the red lines, and then they switched between different types of applications, and then they had another social media session, and then a fair bit of gameplay, which is the green. Now let's look at participant B's day blown up. A lot of purple here. So this person was spending a fair bit of time with video games, and then they do some content creation. Now let's just look at a brief clip that shows you just over a few minutes how much variation there is in what someone does with on their phone. Communication, social media, music, games, back to social media, games, etc. The Screenome software has tremendous potential for helping us classify people's behavioral status, their mental health status, might be able to tell us if they're going to use drugs or if they've recently used drugs, might be able to predict if someone's at risk of committing a violent behavior, what they're eating, their sexual behavior, or how they're managing their chronic disease. And it'll do so by looking at both the images that the person's looking at as well as the text they've been exposed to and the content they've created. Finally, I'd like to share with you how virtual and augmented reality could be used for injury prevention. It's already being used for many, many health conditions. So for example, it's been used to help people on the autism spectrum practice communication and handling social situations. It's been used to help people become more physically active and to engage in outdoor environments while they're in the middle of their apartment downtown. And it's been used to do behavior therapy for people who have phobias, where you can gradually expose them to increasingly arousing images that previously had triggered an anxiety reaction. So the same could be used for injury prevention. You could use virtual or enhanced reality to have people practice driving with or without distractions. You could have them text and then see whether or not their driving behavior is impaired when they text. You could also have them engage in behaviors that put them at risk of violence, have someone call them names or challenge them and see how they handle that aggression, have them practice their communication skills, and the same with substance use. And finally, I'd just like to share the current data on the digital divide. It's not exactly what people conventionally believe. When you actually look at smartphone ownership, there really is no racial difference between white, blacks, and Hispanics, between who owns a smartphone and who does not. But where there is an interesting ethnic and racial difference is on who has broadband in the home and who uses a desktop or laptop computer to connect to the internet. In that case, there's a very large racial difference, with white Americans being much more likely to have home-based DSL or broadband and to use a desktop or laptop to connect. What that means is that apps are generally equally accessible to individuals across racial groups, whereas websites and other things that might be better displayed on a large screen actually might create a disparity, because white folks tend to be more likely to have an at-home desktop or a laptop. So that concludes our presentation, and I look forward to your questions in the live session.
Thank you, Dr. Resnicow. That was a great presentation on emerging technologies and their applications to injury prevention. This starts the live Q&A portion, and I would encourage anyone who has questions to please enter them into the chat so that they can be transmitted to us. We do have a couple of early questions here. One for you, Dr. Resnicow. What do you think is the highest priority innovation to move into the injury prevention space? I mean, you mentioned a number of different technologies that are applicable.
It's hard to say. So it's like a King Solomon decision of splitting the child. I think this idea of behavioral inference, I think we should really investigate, are there ways to detect when someone's either going to buy drugs, use drugs, take out a weapon, use a weapon, and be able to send them just-in-time messages. I think there's a lot of potential there. And to the best of my knowledge, there has not been a lot of activity in that area. The second area, I think, is really moving our NLP so that our chatbots, which many of you are familiar with, are giving much deeper types of responses, much more tailored, much more sophisticated, and so that people really feel they're getting high value out of their interactions with their digital counselors.
I'm curious, just as sort of a follow-up, you talked a little bit about just-in-time messaging, and some of the examples you gave were around geofencing, and it seems like that may be a way to deliver just-in-time messages that could be effective around, so you mentioned obesity and weight reduction as one example. Within the violence and substance use, I wonder a little bit how effective it is to deliver those things, just prior to the behavior. Do you have any sense of that? Or
that's a fantastic question. I think your research, Patrick, will help answer some of that. It very well may be we have to intercept it before the chain has gone too far. So like one of your questions I think you ask is, how angry are you feeling today? Or how much do you feel like retaliating? That might be hours before the behavior. So it might pay to intervene before that point of no return. On the other hand, maybe doing it right when they get near that person, and we may have to, send a pretty loud message, literally and figuratively. Maybe we can intercept it there. These are just important research priorities that your work has gotten us closer to being able to answer.
You mentioned a little bit, you talked a little bit about the digital divide. I'm curious, there are a lot of high-tech features you mentioned. Does that help, does that exacerbate health disparities at all? Does it reduce health disparities? You mentioned some differences in website versus smartphone ownership.
Yeah, in terms of owning a smartphone, there isn't a lot of racial difference. There's still differences by age and urban versus rural, but by race, less so. But where there is differences, again, home access to Wi-Fi, although with 5G and people using hotspots, that will probably disappear in the next 2 to 4 years. What might be a difference is lower income people are often just as likely to own a smartphone, but the cost of that airtime might be more for them. So a unlimited plan may be more painful for them financially. So that's something we might want to consider. But in general, the racial difference in ownership has decreased, although there's still differences. For example, African Americans are more likely to access things through a library and a public computer. Maybe not a good place to do your violence prevention training.
Sure. And thinking just about, Wi-Fi access is certainly something I think in my own work that we've clearly encountered, and thinking about ways of navigating that. Do you see, so you mentioned a number of different technologies and products, and I'm curious, do you see any of these generating profit? Are they a marketplace, or is this, more something for the academic field? And where do you see this going in the future, I guess?
Absolutely. I see tremendous potential for the market. I was actually working with a couple of my clients in my business, Aetna, CVS, and a couple others. They're quite interested in the NLP automated, what they call audit and feedback, but we call clinical supervision. For them to be able to do that in an automated way would save them a lot of money, because right now they're paying people, $100,000 salaries to do that. So I definitely think the NLP agents, and then eventually if we can create these AI counselors, if you haven't seen the product Wobot, that's a very good early entry into the marketplace to handle using cognitive therapy and treating depression and anxiety. I think we can improve on their amazing work, and I do think there's potential profit in this. And in fact, Susan Wolford's app, which we shared with you earlier today, was funded in part through an SBIR, which, as you guys know, is based on the idea that the marketplace has some demand for this. So I think the good answer is yes, although there's a lot of R&D that has to happen before I think commercialization will occur, but I think we're getting close.
Great. I'm not seeing any other questions come into the chat. I don't know if there was anything else that you wanted to particularly highlight, Ken.
Well, just one interesting, I had to, honor your request for a 21-minute talk, so I had to cut out some interesting data. I just want to share, when we looked at YRBS in preparation for this talk, how actually another sort of, I think, counterfactual to the violence word is African American and Hispanic kids are far less likely to report carrying a weapon, but they're more likely to say they carried one to school. So that's an interesting piece of data I think people should be aware of. And also African Americans use substances, except for marijuana, lower than virtually every other substance than white Americans. So that's data I'd hope to insert into the presentation, but the lack of questions gave me an opportunity to insert that here.
We actually have a couple more coming through, and I think we have a couple more minutes. So you talked a lot about different technologies. This question is this something where it could be applied to using positive messages for prevention of suicide and promoted in community schools and colleges, even if there's limited internet bandwidth?
Absolutely. So I think Tom Robinson's team at Stanford is specifically looking at the screenome as a way to detect at-risk behaviors and suicidal thoughts and suicidal searching and suicide content generation. And yes, I think we could use positive psychology and affirmations. It's almost, we're agnostic almost about the content. We can deliver CBT, we can deliver motivational interviewing, although it requires a little bit of special NLP. So the short answer is yes. I think the college population is heavily smartphoned. So yes, there's still bandwidth issues always to deal with, although that general market is pretty well accessed. So I think that's a wonderful untapped thing. David Moore at Northwestern has done some great things in that area. I only was able to share one of his studies today, but a high priority, I think.
Piggybacking on that, it sounds like the answer to this is probably yes, but there's a question that came through in the chat about applying this type of technology to increasing bicycle helmet use. And obviously, you talked a little bit about messages. I wonder your thoughts about either accelerometer data or something around those means in terms of using that to encourage helmet use. It sounds like a lot of helmets have been given away for free in cityscapes, but not necessarily resulting in a change in injury-related outcomes.
So I didn't have a chance today to talk about tailored content. So it's another area that our lab is deeply involved in, of handling barriers and finding meaning. So certainly we can create, I think we've actually done a little bit, as you know, with car safety to come up with tailored messages. So absolutely for helmet use, we can come up with tailored messages. But the question I think was really about tech. So for sure, we can detect cycling. There's some very specific paradata that could indicate you're on a bicycle. Now it's a little bit, this is not just in time. This might be just after time that they may be cycling already, but we certainly, if their phone was on and they had access to it, or we could grab their headphones, we could say, we see you're cycling, do you have a helmet? What would be very interesting though, thinking about that, the various ways how motion detectors, what if we can do some machine learning to say, you know what, you pulling your bike off the rack or you pumping your bike has a very specific motion that we can detect. So I think that's highly promising. And it's the type of thing that these initial studies lead to. So absolutely, I think we might be able to get the precursor behaviors earlier in the chain and maybe before they start pedaling.
Yeah, that's really key to identify those early precursor behaviors. Well, I think we are unfortunately out of time, but I really thank you, Dr. Resnicow, for your talk and for all of the great information on applicability to injury prevention. It's been really interesting.
Thank you, Patrick. Good luck with your conference. And thanks, everybody.